Joe will catch on since we do have quorum. Members of the board, if I could have a motion for the agenda approval. Reno, thank you. And Ed, support. All in favor? Opposed? That's carried. Ed, I noticed you got your hand up. You waiting for a question, or?
You need to ask him a question. I don't have it.
Okay, you're just showing on your that you got you got a raised hand there. Okay, very good. Thank you. Members of the board, any conflict of interest on the agenda as presented to you? None. Normally at this stage here, we do have an update usually from Dr. Ahmed on the COVID-19 update and that. But first, I would like to acknowledge Dr. Ketere, Alexa. I believe she's in, and just to welcome her to our meeting. And first of all, Dr. Ketere, we want to thank you for stepping in for us here for the next little while. And I don't know if there's any update that maybe you could, I don't want to put you on the spot, but if there's any update that you could bring to us in terms of COVID-19 in the vaccinations.
Good afternoon, with pleasure. Thank you so much. As noted, my name is Alexa Ketere. I'm an Associate Medical Officer of Health elsewhere and covering for Dr. Ahmed for a couple of weeks here. I would be glad to present you with a couple of updates about the status of COVID-19 in the Windsor-Essex area. And I will then turn to Teresa for some updates about the vaccine. So while the COVID-19 epidemic curve in Ontario has decreased over the course of the last several months and leveled off, we have observed some increases in the past week or so, and I'll walk you through what that might look like for this area specifically. Looking at our epidemic curve, we see similar trends to the province at large. Our cases have generally stayed the same since the end of the second wave. However, in about the last week or so, we have seen some small increases where we're seeing more than 30 cases a day in this region. Our current 7-day moving average has also increased from last week. So you'll know that we count our weeks from the beginning of January. We're currently in what we would think of as week 10. And so last week in what we would think of as week 9, we saw about 20.6 cases. And this week we're seeing an average of 30.4 cases a day. And that's fairly consistent with what the provincial average is, but it's above what our neighbors in the Southwest region are seeing. So since the middle of January, where we passed the peak of the second wave, both at the provincial level in our region, we've seen cases that are growing at a faster rate than what we saw in December, though not quite as dramatic as what we've seen previously. This is concerning for me, and I think it should be concerning for the rest of the board in terms of what things look like going forward. I think what this represents is that while we've come out of what we think of as that second wave, we should be looking forward into what the next days and weeks look like in terms of what we might be describing as a third wave. Our death rate has decreased dramatically, but our cases have not flattened quite as quickly as what we would have liked to have seen coming out of the end of that second wave. If we look at our weekly rates in comparison to all of Southwest Ontario, our rates are still higher than, as I said, the regions in the Southwest, though consistent with what we see across the rest of Ontario. Turning to testing, if we look at the most recent 7 days worth of test results, the majority of our test results at this point are what we would describe as preliminary. In the past 7 days, the Windsor-Essex region has the 7th highest percentage positivity in Ontario. So we sit at a 2.7% positivity, which is slightly increased from the week previous where we were sitting at 2.4% positivity. And if we look at the percent positivity by age group, all of the groups are relatively consistent. So they're hard to differentiate among all of the distinct age groups. There's a slight increase among younger adults, 18 to age 34 at the moment, where the percent positivity for that group is around 4%. But in general, it's fairly consistent across age groups. We're also doing quite a bit of testing among school-age children. So you will know that there has been testing offered, asymptomatic testing offered to school-age children at a number of pop-up sites that occurred over the course of the last weekend. And the current 7-day average for that group is comparable to the comparable across. So we have almost 2 times. Sorry, our current 7-day average is 5, which is almost 2 times higher than what it was last week, where it was 2.6 cases. When we compare our school age 7-day average to the overall 7-day average, the difference is trending upwards for school age children when we compare that to the average population. And then when we compare to other health units using that 7-day average, we're also able to draw some comparisons where we are, again, fairly consistent with what we're seeing in other health units in this area. When we look at things like how long it takes to get a test result back, when one goes for testing, a person who is tested in the Windsor-Essex area, generally speaking, is able to get a test result back in about 1.5 days. That's a slight improvement from where things were at a week ago, where it took on average about 1.7 days, which I think is, you know, a good news story. When we look at things like what the rate of cases is in the Windsor-Essex area, we look at the case rate per 100,000 people. Overall, our case rate per 100,000 people in this week is 50.1 cases per 100,000 people, which again is a slight increase from what we have seen previously. And I think perhaps I will leave it there and see if there are any questions, and I'll turn it over to Teresa to give a bit of an update about the vaccine rollout.
All right, thank you very much for the report, Dr. Cataray. Any questions to Dr. Cataray on her report today? All right. Then if there's no questions, then we'll ask Teresa to give us an update. Thank you very much, Dr. Cataray, for the report. Very informative. Thank you. And so we'll call on Teresa.
Perhaps if Teresa's not available at this moment, we can come back to her.
Sure.
Oh, can you hear me?
Oh, there she is.
Yeah, there you go.
Oh, that's weird. It sent me a message that, I don't know. Okay, so I'll start again. Did you hear anything or no?
Yeah, we can hear you, but now we can hear you.
Okay, so I'll provide this report, and I just wanted to acknowledge that Christy and Lori have been instrumental in getting the vaccine rollout in our community as well. And Lori remains the gatekeeper of the vaccine and the quantities and the inventory. Lots of reporting to the ministry at this time. And Christy is managing all the other operational aspects of the mobile sites as well as the mass immunization clinics. So we do have, we're going on 2 main sites, WFCU and also Nature Farm Fresh Recreation Center in Leamington are up and running, and they're doing approximately 336 vaccines a day for the 80+ seniors. you will see that coming on board will be Amherstburg at the Libro Center as of March 29th. And between Leamington and Amherstburg, there will be a shared kind of space for vaccinations in the county based on our vaccine supply. We are moving forward with 80 plus people in the pre-registration way is how we've been booking people. We anticipate that with 16,000 people in this age group that have pre-registered, we are likely to complete our 80 plus seniors in Windsor and Essex County by late next week, and hope to start with the 75 plus after that. We are not, the ministry did launch their booking system on March 15th. We are not participating in that booking system. We're using our own at this time and probably will continue to do that, primarily because we're a little bit ahead of the province, and the province booking system is on 80 plus. And if we were to be with their system, we would have to remain with that priority. And so we will move along and are investigating a registration program and booking system where the person goes on and will be able to choose their own time. Right now, that's not possible for the 80 plus. As you know, Windsor Regional Hospital set up their Sportsplex site in late December, and they continue to work on the healthcare workers that are prioritized, the high priority, the very high priority, and the that's the group we were looking at. We did the highest priority and the very high priority. There are 4 categories of healthcare workers, and then we are going to work on the very high priority. They've been immunizing this population as well as adult recipients of chronic home care, which also attended some of our sites. And in phase 2, they'll be moving on to people with medical conditions. So right now, Windsor Regional Hospital is helping this next week or so to finish up the 80 plus so we can get everyone completely vaccinated. They're also opening their site in the Windsor Hall, downtown Windsor area for this population right now. So we're all working together to immunize our the most vulnerable in our community. As you know, Windsor-Essex County is also part of the AstraZeneca pharmacy pilot rollout. And that is specifically targeted for 60 to 64-year-olds. We have 57 participating pharmacies across Windsor and throughout Essex County. We know that it was somewhat of a slow start, but I think all of the vaccinations have picked up based on the Health Canada and NACI statement, which is the National Advisory on of Canada on immunizations. So with that, AstraZeneca, we will probably likely hear more information about the ministry and moving to other age groups with AstraZeneca. In this age group, we know that we have about 28,000 people, 60 to 64, and the pharmacies have been given enough to vaccinate almost everyone if they want it. The other ongoing concurrent vaccination strategy is with the select family health teams, 8 in Windsor and across the municipalities as well, family health teams, the CHC and NP-led clinics. So Christy's been working and prepping this group throughout the whole pandemic. They helped us with testing earlier on, now with vaccinations. So they're each given a certain amount of vaccine, which started this week, and they're vaccinating over 80 plus as well in their practices. And then they will move on to people with medical conditions as we move on with different priorities. In addition, we have a specialty clinic with one of our allergists in Windsor and Essex County who's seeing people that are referred from our mass immunization sites, as well conducting his own 80 plus run clinic. And the final rollout strategy is the mobile teams through Essex Windsor EMS, as well as our own internal Windsor Essex County Health Unit team of nurses. And as you know, long-term care and retirement homes were completed, but we continue to provide vaccinations for people that require them in the new residents. And this is the only, with the delay in the second doses for every sector, this is the only sector, the residents of long-term care and retirement homes, that will get a second dose if needed, but all other doses are delayed for 4 months. There are some efforts going with the homeless shelter as well due to the outbreak. So some people have been vaccinated through a mobile team there. And as well, we're working with Community Housing Corporation and EMS and our nurses to vaccinate seniors, homes in the community, like, and I mean homes, I mean like apartment buildings, and that are really populated with people that are in the older 80+ age group. We are using all of our vaccine every week. We are getting approximately 14,000 doses of Pfizer a week. That drops off in a couple of weeks to about 10,000, and we're getting a small amount of Moderna as well. Overall, we're seeing between 16,000 and 17,000 doses a week in our community, and through all of these mechanisms and the hard work of all of our staff and the community partners, definitely, we're getting it moved very, very nicely at this time.
Okay, I do have, at first I had Alexa's hand was up, Reno, and then Larry.
I just noted that there was a question in the chat about where cases are located in the community, and I thought I might spend a moment responding to that, if that was okay.
Yeah, go ahead.
So I wanted to note that, you know, roughly within our community, the distribution of cases among people based on their age and sex is approximately equal. Again, we do see a little bit of an uptick among cases that are in our younger population, that 18 to 34-year-old age distribution, but we're still watching to see whether or not that is a consistent trend. I think the question was specifically around whether cases are related to individuals who acquire their illness from a situation where there's an outbreak, or whether it's acquired elsewhere. And that's a little bit more difficult to separate out. What we know is that about 15% of people aren't sure where they acquired their disease. We aren't able to link that disease to a specific setting. Though it is area dependent, so it's dependent on which part or which municipality, roughly 1/3 of people acquire their disease from somebody with whom they live, a close household contact. Another 1/3 of people acquire their disease somewhere in the community, and another 1/3 of people approximately acquire their disease somewhere else. And that's approximately consistent across all of the places where this health unit serves. As of this week, we are actively following approximately 15 outbreaks, though that changes day to day as we declare and then rescind new outbreaks. And that's increased from about 12 outbreaks that we were following last week. And the doubling time of the number of cases that we follow is about the same as what it was last week. One of the numbers that you might keep a close eye on is our effective R0. That's the number of new cases that each person who has illness might generate. So the number of people who one new case of one person with disease has the potential to spread it to. And ideally that number we try to keep below 1, because that means that every person who gets sick has the potential to make fewer than 1 new people ill. This week, that number is below 1. It's 0.9. Though again, that number has the potential to change at any given time, dependent on what's happening in our community. So we don't want, you know, I don't know that we can feel really secure about that number, but that is a potentially good news metric. And I hope that that responds adequately to the question.
Okay, thank you, Dr. Cattery. Reno, Larry.
Thank you. To speak as well, too, please, Gary Kashak. Thanks.
Yeah. Okay. Gotcha. Yeah. Just you know, for clarity as well, is that the little hand. Just raise your hand, and that it'll be. I'll be able to acknowledge. It's right on your bar, just down below. Okay. Go ahead.
Thanks, Gary. Question is for Teresa, and just circling. So first off, I just want to say great job on every tangent that you're working on. Very visible, very obvious in the community that you're working across so many different groups and collaboration. So great job on that. My question is specifically as it relates to congregate living settings. So there are homes in the community, and I've received a lot of calls in the last week or so from residents who are feeling a little bit desperate in the sense that they feel like if it's shut in and locked in, so they're living in housing with supports is the category, is how we describe them municipally. I think there's nine or 10 in the city of Windsor. So these are nursing home type style living, but not seniors, servicing not seniors. So do we have a plan as far as to include them in some sort of hierarchy when it comes to phasing them in? You know, long-term care is done. We're doing congregate settings with the shelter system. We're starting with the higher age groups. Do we have a plan to address these style of homes that are specific congregate living homes, but are not necessarily seniors?
So the plan is actually in the provincial plan, and all of the congregate settings that are outside of seniors are included in phase 2 of the plan. So the plan will continue to be at our age risk, our age categories, going in 5-year increments below, like 75, 70. And then the next would be at-risk populations. So that's where you get people with medical conditions, but also the congregate settings. So they're part of that strategy, and they would be included at that point. That's where the mobile testing, or mobile vaccination teams working with EMS, our own nurses, will be, that will be the focus. Right now we're doing what we can with the vaccine that we have. And I know you're probably getting the same questions we're getting, and we're moving as quickly as we can, but the congregate setting in and of itself is not just an automatic, eligibility for the vaccine at this time. And so with congregate settings, you'll get every area across. This is where the farms would come in as well. So when you talk about further prioritization of those settings, it'll be based on the vaccine and the resources. So that's very different than having mass immunization clinics where we're going into the homes. As well, we're receiving questions from people who cannot access a vaccine anywhere else, cannot go to a clinic, and are someone in their home. And we will be working with EMS as well, and also community and home care to figure out how to vaccinate those people, but probably not with the current vaccine. Moderna and Pfizer is a little bit trickier to move one dose at a time, and with other vaccines, primarily AstraZeneca, we'll work with that to, further make sure that everyone who wants a vaccine gets it.
Okay, and just a follow-up, do you have an idea of when phase 2 would start, or what sort of timeline we're on to then lead to phase 2?
So phase 2 and really should begin when everyone in phase 1 is done, and we're coming close to all of that. So phase 1, as you know, are the seniors over 80, the congregate settings of people over 80, primarily long-term care and retirement homes, and healthcare workers that are at that, the very highest priority. So we're moving through phase 1. We're at the tail end of phase 1 and moving into phase 2. And I do believe that next week, as we finish up the people that are registered with the 80+, we will be, getting into the 75+, and that may be the unofficial start of phase 2, but still continuing to finish up healthcare workers and, that have been prioritized.
Great, thank you. And again, great job on all fronts. Appreciate it.
Yeah, thanks, Reno. Larry Snively.
Thank you, through the chair to Teresa. I know right now the AstraZeneca, okay, that vaccine, okay, I'm going to refer to the European countries that they discontinued it or stopped using it. Are we having any reactions whatsoever at this part over in our part here. Is there any reactions to that vaccine?
So I can start and tell you what I know today, that the pharmacies have been giving out AstraZeneca in Windsor and Essex County, and we have not had any adverse reactions that have been reported. They are reportable to our health unit and also to, to Health Canada. I'll let Alexa, as the physician, speak about AstraZeneca, but there's no concern from our end.
Yes. So from my perspective, the best vaccine I think that you can receive is the one that comes closest to you. Vaccines that are authorized for use in Canada are reviewed very closely by Health Canada and by our National Advisory Committee on Vaccines, and they are authorized for use because they are safe and effective. In response to your comment today, the European Committee on Vaccines did actually come out with a statement that they have reviewed the evidence and that the AstraZeneca vaccine is safe and effective for use, and that they're encouraging its use in all countries in Europe. That statement was echoed by the World Health Organization and the United Nations Committee on Vaccines.
Thank you, Doctor, for that. I'd like to have that somehow put out to the public, because there's a lot of public today, even in my area where I live, will not get that one because they're afraid. They're afraid of blood clots. So that's why I brought that forward. Somehow, I don't know if the board can get that out there, or not the board, but the Essex Health Unit, if they can post that somehow on their website, because there's a lot of concern out there right now with that vaccine, and there's a lot of people out there that won't get it, and that's a big problem.
So I'll just comment, we have really put all this information on our website. We have another exceptional job by some of our managers that have been reviewing the information and populating it every day, every night as information changes. So it is all on the website. It's currently linked. We have shared that on our YouTube. We've answered questions in the media. The Ministry of Health has also sent out a lot of information. The word is out there. We do have AstraZeneca in our community, and we've been actively promoting it the best way we can and answering any questions and allaying any misinformation that's out there.
Good, thank you, Teresa. And just further, I'm going to echo what Reno said. I said it at County Council last night, and Gary's aware of that. He was there. A great job. And I'll tell you, I'm getting a lot of positive feedback from people that's gone to the vaccine centers in Windsor and Leamington. Very, very professionally run and well done. So congratulations on your whole staff.
Well, thank you. And just another shout out to the municipalities who are really supportive. I just need to acknowledge the hard work of everybody. The municipalities are also getting trained in the ministry's COVAX system to help with registration. And again, a real, it takes some training on our part from our IT people, but to have that added support across the mass immunization sites is really amazing. And Dan continues to hire and populate those sites and schedule people. So it's all coming together, but thank you for that.
Yeah, you guys are doing a great job.
Just on the AstraZeneca, I'll gladly be the poster child, because if it's available and I am entitled whenever that happens, I'll gladly roll up my sleeve and accept the vaccine. So with that, you're next, Ed, and then Gary Kasha.
Thanks, Gary. Can you hear me well?
Yes, I can.
Okay, that's great. I have 2 to 3 questions, and they are really short. I don't need a lot of dwelling on them. And the reason I kind of want to ask, because my constituent had been calling us, actually, not calling the city, but calling their councillors. And if you can give me just an idea of what the proper answer for that. The first one, I think Teresa was saying kind of everyone will have 2 shots at the vaccine. it'll be the first shot and the second. Is it, and I think I heard saying, Teresa was saying, if it's needed. Is it really is up to the discretion of the health unit if it's needed?
Oh, sorry, Ed. It's a 2-dose. All the vaccines out there that we have approved in Canada are 2-dose vaccines at this time. So second dose is needed. It's that the direction from the ministry is that the second dose is delayed till 4 months from your first dose. So typically it's a little bit of a closer schedule. But right now, anyone who's getting a first dose will be getting a second dose in 4 months, and it is a 2-dose schedule, and it is needed. Alexa, did you add to that?
Yeah, you answered this. Go ahead.
Janssen is a 1-dose vaccine.
Yeah, Johnson & Johnson, but we don't have access to it here in Windsor-Essex County.
I think I have a question. Probably I don't know how important it is. I think I heard maybe Dr. Ahmed once mention it. Is it possible for people to get sick between doses, between the first and the second one, if they are healthy and possibly they go for the first shot, and if they end up getting the infection again or getting the virus between the 2 shots? Is it possible?
I'll let Dr. Cadaret comment, but yes.
It's certainly possible, though the likelihood of that is very low.
But basically, the first shot would offer some protection from getting the disease, isn't it?
The first vaccine does offer protection. It offers good protection, likely up to and upwards of 85% protection.
Wow, that's great. I know one question had been asked before. I'm not sure if it was Reno Bertolini or somebody else. And how can we coordinate, for example, in household, you have husband and wife, but they are varying in ages. Could possibly be, some of them might be on the first group or could be on the second group. Is it possible for the health unit or possibly maybe from you to coordinate so both of them can get the shot at the same time?
So Ed, that's a very good, a good suggestion, and that's what we have aimed for as we roll out the booking schedule. So for the 80 plus, it was a pre-registration system, and it wasn't feasible to do that. And I could go on about it, but it'll just seem like excuses. But we did really try to have that be part of our system, and it just wasn't, we weren't able to accommodate that. But as we move into other groups, we are working on our new booking schedule to accommodate people in the same household. I don't know how many people, but at least, another person to be able to be vaccinated at this, to schedule their appointment at the same, similar time.
I just want to say one thing. I honestly believe we have been very fortunate. We have very competent staff, and we got Teresa. We've been getting help from the province and from other health units. I'm really grateful to all the help we've been getting, and thank you.
Thank you, Ed. Gary.
Thanks very much, Chair, and good afternoon, everyone. Just to follow up on what Mayor Snively had to say there, I did actually get the AstraZeneca shot on the weekend. I'm in that 59 to 64 age group. No problem at all. It was smooth. It was a few of us in that age group got it done with no after effects. So very happy to have gotten that done. I guess my question would be for Dr. Cadaret then. So 59 to 65, getting it done now, depending on, what type of time of the year you were born in. When is it going to be available for the 65 to 79 group in Ontario, like they say it's going to happen? Can you give us an update on that, please?
So the National Advisory Committee on Immunizations has reviewed the evidence and has made a recommendation that this vaccine should be made available to that group. And so at this juncture, we are waiting on guidance from the Ministry of Health about when we might be able to start providing this vaccine to adults who are over age 65, so between that 65 and 79-year-old age bracket. So we're truly just waiting on further information from our provincial colleagues.
Thanks, Dr. Catteray. So it could be as soon as a week or potentially longer? Or?
I would anticipate that that direction will come soon, and I, like you, am waiting and hopeful.
Okay, I appreciate that answer. And for Teresa, thanks again, Teresa, on everything that you and your staff are doing. You've touched on community housing corporation residents. We had the 2455 Rivard building with 350 plus seniors in that building. Of course, they're not all 80 and over, but is that a phase 2 situation where the whole building will be done, or are we only looking at 80 and over right now?
Right now, we are doing 80, maybe some 75-year-olds as well, and above. So we're keeping very close to the provincial guidelines.
And Teresa, would that be right in the building, or are they going to have to go outside elsewhere? I've heard some mixed statements on that.
Right in the building, like
yeah, EMS, Gary. I know I talked to Chief Crowder yesterday. They're actually in the building.
Okay, and that's what I thought. I just had a voicemail 2 hours ago from somebody from that building, says that they couldn't get it done in the building. Now, we're not sure exactly what their age is, but so the 70 and up and moving from there. So that's great to hear. Thanks, everyone.
Yes, and just on the AstraZeneca as well, it's good news. The Biden administration now has allocated 1.5 million doses coming to Canada from the U.S. and so that's great news. So kudos to the federal government that we're able to secure another 1.5 million doses. Any further questions before we move on? All right. Well, thank you very much, Dr. Catteray, for your in-depth report and certainly on the questions and answers, and to Teresa as well. It is remarkable that I think 51,000 doses have been administered, or 51,000 I think total. When we look at the provincial totals and the Canadian total, we're very, very fortunate to have a great team that has done phenomenal work in the area. So when you look at the percentage, we're way ahead of the game. I don't want to say it too loudly because I don't want to jinx us. We want to continue to have the flow of vaccines into our region, and so that's good news. All right, we'll move on. If there's no further questions, we'll move on to the approval of the minutes of the special board meeting of March the 4th. If I can have a motion on that. Reno and Larry, on those minutes, any errors or omissions as presented? I've heard none. All in favor? Opposed, if any? That's carried. Thank you. Any business arising from those minutes? I see none, so we'll move right on to the consent agenda. We have 3 information reports. The active school travel fund awarded to Windsor-Essex, the risk management, and also the January-February communications recap. If I could have a motion to receive the consent agenda. Tracy and Ed, all in favor? Opposed, if any? That's carried. I'll just, for information's sake, if there's anything administration want to highlight out of those 3 reports that at this time.
So we do have a presentation by Mark Fry on the risk assessment. This is a document that goes to the Ministry of Health along with our budget submission. And so he has developed some slides for us, and we'll walk you through some of the key risk items. This isn't the whole report. We will be providing further, a more comprehensive report in another board meeting, but I'm going to turn it over to Mark to just walk us through that one report.
Okay, thanks, Teresa.
Hi there, everyone.
Hi.
So I'm just gonna get my slides up here. Hang on one second. So we all able to see that?
Yes.
Yes.
I
Great.
do not have, okay. Here it comes.
Okay, if we're all set, so what I'll point out is I'm sharing this on my own monitor, so I can't see if you have any questions, but I know questions can come afterwards, but don't hesitate if you have questions. Feel free to stop me. I won't be able to see if your hand is up or if you wanted clarification on a single point, so don't worry at all. You won't offend me.
Okay, Mark, I'll keep you posted. I'll be able to pick up from
Oh, perfect.
for a hand if you do have any questions. I know Ed, you still got a raised hand there, so if you could lower your hand unless you have a question.
I'll take the silence as a
Okay.
no for now.
All right, so right now you're good to go.
Okay, nice, perfect. So I'm Mark Fry. I'm our manager of our Planning and Strategic Initiatives Department at the Health Unit. And what I'm going to do is walk you through our risk management reporting to the Ministry of Health. So this occurs yearly in Q3. And what the ministry asks us to do is report on our high residual risks. So the distinction here is you can have inherent risks. So how likely or how impactful that risk is to your operations without any mitigating strategies. And then when they refer to residual risks, what they're referring to is where we've already thought of how our mitigating strategies might reduce the risk, and is this still a high risk for us? So they ask for up to 10 high residual risks to be reported to them yearly. And they also ask for these to be reported using common language. So they have categories that don't necessarily align with how we have been doing our risk management internally. So some of our categories are collapsed from our original risk registry to fit into the schema that the Ministry of Health is asking us to use. This is probably going to be repeated throughout the presentation, and you probably could guess this, but a lot of our risk management approaches have been dramatically impacted by the COVID-19 response. So not just our mitigation strategies, but also what we categorize as a high risk has been influenced by the pandemic. Again, probably not a shock for those of you on our board, but something I will point out. So I'm going to walk through the risks that we reported because I think it's important that we all understand them, but I'm not going to go into them in depth. I know you have the report available to you to see exactly what we provided the Ministry of Health. But a couple things I'll point out on my slides, you're going to see the name of the risk, and then you're going to see right here where it has an I and an L. So that represents the perceived impact and likelihood. So the Ministry of Health uses a 5-point scale for each, giving a product a potential total of 25. So anything that the product scores greater than a 12 is deemed to be a high risk by the Ministry of Health and acceptable for reporting as our high risks. So these numbers here represent the perceived likelihood and impact of the risk that's being identified. So one of the highest risks that we've identified pertains to our finances. Again, probably not a shock for our board here, but external factors could dramatically impact our capacity to meet our organizational objectives and to operate effectively. And I think that's been even more pronounced during COVID-19. While we do get budget augmentations, it's still always a challenge. We're very conscientious of our money and how we spend our money at the health unit. And so one of the primary actions that we're trying to take to mitigate this, both in the near term and the long term, is to continually evaluate our budget and ensure that we're very conscientious and thoughtful with how we use the funds that are provided to us. Another looming risk that we've identified is changes to the public health system. So as you may recall, there were proposed sweeping changes to public health as it operates in the province. And this modernization effort, I think, has been impacted by COVID-19, but it's certainly not gone away. And I think it's something that we're still thinking about and considering. And it would dramatically affect our capacity to meet the Ontario public health standards in our community as dictated by the Ministry of Health if these larger scale changes were to be enacted. And so our major action that we are taking to mitigate and prepare for that is to ensure that we're engaging with the province and our partners regarding any public health modernization efforts. Admittedly, those have slowed a bit with COVID-19, but we try to stay as monitoring it as closely as possible, just so that we are on top of those changes. Another, and very timely, but another large or high risk that we've identified is that of disasters and hazards. And actually, I will note that this was scored lower in our previous risk assessments. And I think because of COVID-19, it's become readily apparent the impact that this disaster has had on our operations as well as the world's operations. And one of the clear consequences that we've seen is just increased need for resources, whether human or financial. It's become very difficult. And so what we've tried to do as an action is to develop plans so that we can try to mitigate any of those risks long term. So not only with our COVID-19 response, but even prior to the second wave, we were having a lot of conversations internally about our programs and services and what would be appropriate depending on the amount of cases or depending upon the demands related to COVID-19. So this is something that we are continually putting thought into. And another risk that I think is exacerbated a bit by the pandemic involves planning and information. And really just our capacity and ability to collect information, to evaluate our operations, and then to use that to inform how we provide our services to the community. So one of the major risks here is we're so focused on COVID-19 and addressing the pandemic that we may not be providing some of the services that we usually would in the community, nor are we then evaluating them or collecting data from the community. So there's a risk over time that we may become misaligned with the needs in our community because of that. So our plan here is to try to maintain some of these ongoing programs and services and data collection approaches. And I know behind the scenes, we have a lot of really interesting work happening with an EMR system to capture data in real time when we work with clients. So I do think we will be able to do some of this work, but definitely COVID-19 has dramatically impacted our capacity in this area. And another high risk, and one that has occurred recently and could occur again, is a work stoppage. And this would be if we had difficulty reaching a collective bargaining agreement with some of our unions. And this would lead to disruption of service, obviously, in our community. And so I know that there's a lot of background work happening, just coming up with plans and ensuring that we're ready. And hopefully this never occurs, but just preparing in case that does happen. And then we are currently at risk, I would say, of not meeting our proposed organizational strategic priorities. And partly, I would say this is a function, again, of the pandemic and its impact on our operations. And because our strategic plan and our strategic objectives were set out in such a way to try to move us forward with our relationships in the community and to improve our programs and services, not meeting those objectives does run the risk of impacting our quality of service and basically what we are providing to the community. So what we've done internally when we've looked at that, when we've had time to look at our strategic priorities, is try to assess what we could do given our current capacity, and also with consideration of the pandemic and the demands in our community, and try to prioritize those, recognizing that our strategic plan will be done in the coming year. So that is another thing off in the future that we'll need to start considering. Another that we've identified is privacy breaches. So increasingly, we're reliant on information in technological resources or databases, and there is a risk that that information could be accidentally disclosed, or personal health information could be accessed by third parties. And the consequence here is potentially financial or legal issues. And so what we've tried to do is ensure that we're providing training and support for all of the systems we're using, including new systems that are being provided by the Ministry of Health, and work in consistent auditing practices to ensure we're compliant with our requirements. And then the last on the list here was local health disparities. And again, I feel like I keep repeating the pandemic has impacted us, and we all know this, but I think more than ever, we're at a risk of having increased health disparities amongst those priority populations in our community. And one of the consequences I think we're likely to see as a result of the pandemic is just an increased burden of illness and poor health outcomes amongst those groups, just given how the pandemic has affected different groups. And so we had planned and continue to plan to engage with our priority populations in a thoughtful and effective way. As well, I know that we have work going on related to language services to try and make sure we're meeting the needs of our community. So this is something near and dear to our hearts at the health unit, something we're working towards constantly, and the work won't end after the pandemic is done. We'll have to continually work with those in our community to ensure we're meeting our optimal health outcomes. Oh, I'm sorry, I apologize. There's another one. So there is also a risk that we may not be able to provide our programs and services with the fidelity that we had planned in our annual service plan due to largely the pandemic. And so this decreased capacity could mean that some of the longer term plans and programs that we had in place or had planned to have in place might be impacted long term in how they influence our community. So not only are we doing things in the near term, when we're interacting with the community, we're hoping for long-term systemic changes. And when we're unable to continue those programs, that long-term outcome becomes at risk. And so what we're trying to do is prioritize our programs and services both during COVID-19, but also after the pandemic is done so that we can maintain that level of impact in our community and make a difference over the long haul. So that summarizes the risks that we identified for the Ministry of Health. What we're planning to do next is update our risk registry internally to reflect those changes that we provided to the Ministry of Health and ensure that they're one-to-one match. Some of, like I had mentioned earlier, some of the categories are different, so we're going to make sure that those are aligned. And we're also going to try to implement our mitigation approaches. But again, this is a challenge because so much of our effort and so much of our time is focused on the pandemic that it is difficult, I'll admit, to squeeze these operations in, but we're going to prioritize those and ensure that we're mitigating those risks appropriately. And then maybe more of a longer term project, but something we aspire to do is to create consistent key risk indicators so that we can monitor the progress, not only in terms of mitigation, but if a risk is getting worse, we can use that to quantitatively assess whether or not we need to address it in a different way. So that's the summary, and I'm happy to answer any questions you might have, and I will stop sharing my screen. Oh, apologies there. And you're seeing my messy backdrop. I am so sorry.
Not a problem. Yes, thank you very much, Mark, for the report. I have Tracy Bailey. Go ahead, Tracy.
Thank you very much. Appreciate the presentation and also your in-depth look at the risk and what it's going to take to recover from that risk as well. Question that I have is, one would be, do you think that with the strat planning that's in place coming due within a year, I realize time is certainly a challenge these days, but is there an opportunity that we should be looking at that strat plan potentially a little bit sooner so that we can build in some COVID recovery into that plan and maybe hopefully be a little bit more resilient? Appreciate that you talked also about matching up your internal risk. That's an important factor, and I was happy to see it in your presentation. The other question I guess that I have in terms of rolling out through COVID recovery is whether or not there'll be some opportunity to really take a deep dive look at whether or not there are some things that are falling off and are currently a risk, but could be services that are delivered by other organizations within our community.
So I will definitely take my best stab at those questions, and then Teresa or anyone else, please feel free to chime in. But what I would say is the strategic plan, we had ambitions to be much further along, and the pandemic has definitely impacted those ambitions. But I can speak from those I've talked to, it's a priority for us internally. It's something we take very seriously. We'd like our strategic plan to reflect the needs of the community and to be impactful, not only in how we operate, but as an outward manifestation to the community about what we do and how we do it. And so I don't know that I could commit to any escalated timelines. I think that would be something Teresa would need to comment on, but I definitely can mention that it's a priority for us and we want to do it well and we want to do it thoughtfully and we want to make a difference. And then to your other question about plans for programs and services, we did look at early on what would be impacted, and we've tried to maintain as many programs and services as possible. But I think time will tell how that actually impacts us over time. And I couldn't really comment on whether other organizations would be able to fill those gaps. But Teresa, is there anything you'd like to add?
No, just that it is a priority. We had talked about the strategic plan, and it is something that we know that is coming up, and we need representation from our board. Even since the the rollout of the plan, the members have changed, even our board membership. So that's all on our radar. When you're asking about timelines, I can just I can't stress enough that all of us are, have not really deviated from the work of COVID. And I think things will hopefully get better in maybe the third quarter of this year, but there are many priorities for our health unit that have to be addressed, and the strategic plan is one of them. And also, like you said, reassessing our annual service plan and what we will continue to move forward with, and what we now have learned that maybe we will not prioritize, and all of that would come to the board. But right now, the focus is still pretty much remain the pandemic and now the vaccine rollout, in addition to the ongoing work of the outbreaks and the COVID case and contact management.
Okay. Any further questions to Mark on his report? The only point that I'd like to add is for the board's perspective, as well, as when 45% of the board is now gone, and it's you're looking at populating the board with new members, which would be great. But it's at this stage of the game, as we all know from what we faced in the last year, it's going to be a very, very steep curve for individuals, and for sure. And I don't know, Dr. Cataray, if you've got any pull, and certainly in the ministry. I'll tell you, exercise whatever pressure you can, but I can tell you that if anything, it's very, very difficult to continue to move the yardstick on because as much as the pandemic has been kind of front and center, there are so many other areas of responsibility that the health unit has to certainly fulfill. And it has been extremely, and I'm sure with your board, probably no different, and your organization within the health unit in Toronto, it's been extremely stressful to all of the members. Many have I've worked almost continuously for 12 months, and it is, it's taken its toll, and certainly so forth. But that to me is one of the biggest pieces. The partnership between the board and certainly our senior management team in particular is very critical, and but also making sure that the board fully understands that it takes a lot of tools to fill the toolbox to do the job and to be able to understand. I've been a long-serving member of this board, and I'm still learning today. And so I don't certainly envy the task at hand, to get our numbers up. But you can see from the presentation. Thank you, Mark, for that work. And I know it's taken a team effort to put that all in there, but to be able to identify certainly the risk at hand. So thank you for that report. And if there's no further questions or certainly comments on that, then it's been received already, and so we'll move on to new business. So with that, on new business, we have a lot of correspondence. A lot of it is letters of support, especially on the mandatory sick leave. And I think we've sent our own. I think Nicole, we've certainly supported a lot of resolutions that have come about, including our own. So would it be proper at this stage here that we receive these letters, or are they looking again for support from the board?
Oh,
Nope. Crickets here.
I don't know if I hear Nicole.
I'm here. Are you talking to me? The
Yes.
letters, are you saying, are we looking for support, or?
Yeah.
Well,
Yeah, we have not, that I'm aware of, brought forward a resolution specific to this, so we would recommend supporting it. Yes.
Okay, that's what I was looking for. Moved by Tracy, supported by Larry, that we support the letters to both the federal and certainly in the province in support of. No further questions. All in favor? Opposed, if any? That is carried. Okay. All right. I'm going to need a motion to move into committee of the whole. Reno, Ed? All in favor? Opposed, if any? That's carried. There's really no further, unless there's no further business to deal with here, but certainly, Leanne, I'm going to wait for you to